I have the privilege and the pleasure to be the chair of the program track for metastatic non-small cell lung cancer. And I think we have a lot of exciting data which really will change the way how we can treat our patients with advanced non-small cell lung cancer.
Well, shall we start with a brief overview of the highlights and then dig into the details?
Well, when we talk about the highlights, in principle, in management of advanced non-small cell lung cancer, we have two tracks. Number one is the identification of oncogenic alterations and something that we call the targeted therapy. So the way to target the molecular alteration in the lung cancer. The first example has been the EGF receptor mutation, where we have developed specific oral drugs, tyrosine kinase inhibitors, which have shown overwhelming efficacy. And we are moving on that field, so we have got a lot of update and new information here. For example, we have a new drug, osimertinib, which is a third generation EGF receptor tyrosine kinase inhibitor. It has shown a superior efficacy compared to the old generation of TKAs. Here at ESMO, we are talking about the mechanisms of resistance. So this is really important when we are developing new treatment strategies to overcome the resistance to treat people progressing on this therapy. So we have two exciting talks here at the ESMO. We have novel targeted therapies, so in particular the MET alteration, MET amplification, MET mutation is an interesting target where I would say we have moderate opportunities for treatment. Here we are seeing very interesting data on a new drug, capmatinib, in patients with MET alterations. We will get new data in the second track, and these are immunotherapies. So when we talk about the group of patients with oncogenic alterations, these are probably appropriate 20% of the patients approximately. But we have the 80% of Caucasian patients who are something that we call wild type patients. We do not find any treatable oncogenic alterations. And there we have made substantial progress with the development of immunotherapy. So we started with the monotherapy with immunotherapies in pre-treated patients. Now we are moving forward. We are transitioning into first line. We have the opportunity to give selected patients a monotherapy with a checkpoint inhibitor with pembrolizumab. And now we have a growing incidence that a growing body of information that the combination of chemotherapy and checkpoint inhibitors is associated with a significant improvement in progression-free survival and also overall survival. And we are going to see new data here at the ESMO conference. We are going to see first original data of a combination trials and a lot of more information about this exciting field of immunotherapy.
When it comes to the benefits seen for immunotherapy and molecular therapy, they're of course limited by biomarker expression. Can you tell me what's being done to try and make these therapies more widely available to patients, to find out who gets what and how to make the best use of them?
Well, this is still work which is in progress. And as I mentioned before, we have developed the monotherapy for certain patients with a high PD-L1 expression on the tumors. This has been the first marker that we assessed in lung cancer for immunotherapies. Now, when we look on the combination trials, we have to say the combinations seem to work independent from the PD-L1 expression status. So we do see this enhanced activity, of course, in the PD-L1 positive patients and in the patients with high PD-L1 expression, but we also do see the efficacy, the improvement in the PD-L1 negative patients, and these are approximately 50% of our patients. So the combination with immunotherapy is one instrument to open the indication of immunotherapy. Of course, we are looking for predictive markers, but this is a very challenging story. This is an exhausting story. We have to define this biomarker. We have to validate this biomarker. Something which potentially will help us is a new biomarker, which is tumor mutational burden. So we have identified tumor mutational burden as an interesting biomarker besides the PD-L1 expression on the tumor cells. We have seen that tumor mutational burden is a predictive marker for the efficacy of immunotherapy, in particular for the efficacy of immunotherapy combinations, and perhaps the combination of several biomarkers, like the combination of PD-L1 expression and tumor mutational burden, might help us really to select patients better for the use of immunotherapy or immunotherapy combinations.
And then with a lot of the research you mentioned there, novel agents coming out, are there any exciting early stage trials which you think are going to show promise over the next few years as data collect?
Well, there are a couple of exciting trials and they are also presented here at the meeting. The problem is a little bit, when you look, for example, on the combinations with immunotherapies, you have numerous trials, numerous extremely interesting approaches that are currently under clinical investigations, but we are just at the beginning. It's really hard because we are talking about trials with 6, 8 or 10 patients, and it's extremely difficult to get a flavor whether this is a promising agent or whether we are going to see this agent in randomized prospective trials in the next years. We have a couple of very interesting concepts, in particular when we talk about immune modulation. We are talking about vaccines, we are talking about additional checkpoint inhibitors besides PD-L1 and anti-CTLA-4. We have the OX40, we have the GATR, and we have other checkpoint inhibitors that we are using. We are talking about other immune modifiers. We are talking about ways to improve the T-cell primings. We are also using something like artificially prepared tumor-infiltrating lymphocytes in lung cancer now. So we have a whole spectrum of exciting new approaches, but I think currently it's too early to make any clear expectations what we are going to see in the next years.
I guess we'll just have to come back and talk again at ESMO 2019 and see where we stand. Okay, well, I think that covers a lot of the lung cancer content. Is there anything else that you would like to mention?
Well, when we talk about immunotherapy in thoracic tumors, I think it's worthwhile to consider that we really have made progress. So we are talking about combinations, but we are now moving to new areas, and we have 2 avenues in lung cancer. Number 1 is to go from metastatic stage of disease to earlier stages of disease. So this year we have seen the Pacific trial investigating a consolidation treatment with an immunotherapy after chemoradiotherapy in non-metastatic patients with advanced non-small cell lung cancer. And we have seen a significant improvement in progression-free survival and overall survival, and this really changed the way how we are treating our patients. And we are now going even more earlier into the field of resectable non-small cell lung cancer. We have seen very exciting data on resectable early non-small cell lung cancer. We are evaluating this field in randomized trials, but this is definitely also a huge area of interest. And the other avenue besides looking on earlier stages is to look on other histologies. So we have seen for the first time a positive trial with a combination of immunotherapies in small cell lung cancer, and this really will change our management. And we do see success also in the management of pleural mesothelioma.